Early childhood development is a multidimensional concept, which means different things for different people. From Thrive's perspective, we want to look at it holistically, ages from conception to age 8. We focus on health, nutrition, early learning, responsive caregiving, and child safety and security as drivers in the child development process. In terms of outcomes, we look at things like health, nutrition, cognition, and socio-emotional development.
We know that early childhood interventions can be very effective and have persistent, large effects on a multitude of outcomes. What we don't know is how to adapt these models to be able to implement them at scale within the tough constraints of the poorer countries.
Scale-up by itself is a science. It must be planned. We must look at the factors that enable it and how do we give it the best possible chance of success. We have to influence policy, and policy thrives on evidence. And I believe that's the gap that Thrive will be able to fill. Where there is anecdotal evidence, it's an opportunity to test it and be able to provide policymakers with the information that allows them to confidently make policy choices, and in particular invest the limited resources that the country has, because they know that this is backed by science, this is backed by evidence.
To find out more or support this project, get in touch.
Hello, everyone. I'm Marliese Morsink, Deputy Program Director for Thrive at Oxford Policy Management. Welcome to this fourth webinar in the Thrive in Conversation series, and thank you for joining us. I hope the short film that you've just watched has given you a helpful introduction to Thrive and our research, which focuses on scaling early childhood development services in low and middle income countries. We aim to fill existing evidence gaps and point out critical areas for further exploration. In our Thrive in Conversation sessions, we invite researchers and policymakers involved in early childhood development programs to discuss their experiences and share their insights, particularly lessons learned and challenges faced during scaling. In today's conversation, we will consider what it means to scale successfully and reference a framework of indicators for horizontal and vertical scaling developed by the research team. We will also discuss enablers and barriers to horizontal and vertical scaling, drawing on the experiences of two playful parenting programs in Bhutan and Zambia that were intentionally scaled up over 5 years with the help of funding from the LEGO Foundation. I'm honored to be joined by Karina Umueva from the research organization FHI 360, where she is the Senior Director for Research and Evaluation based in Washington, D.C. Francis Aboud, Professor Emerita in the Department of Psychology at McGill University in Canada, and Legden Zed from the Ministry of Health in Bhutan, where he is a Chief Program Officer in the Department of Public Health. Karina and Francis were part of the team that conducted implementation research on 4 parenting programs between 2020 and 2025 to identify enablers and barriers to scaling, as well as examining caregiver and child outcomes at scale. Legden led the implementation of the Playful Parenting Program in Bhutan on behalf of the Ministry of Health in partnership with Save the Children. In a moment, Karina will share the team's insights into scaling in a 20-minute presentation. Then we'll move into a conversation with Karina, Francis, and Legden, followed by time for audience questions. We would very much like to hear from you during the webinar, and there are 2 channels for this. Please use the chat tab to introduce yourselves to each other and for sharing thoughts and reflections. But please use the Q&A tab for specific questions you would like to address to the speakers, and indicate who the question is for if that's relevant. We'll endeavor to answer as many questions as possible during the webinar, and all questions, comments, and feedback will be reviewed by the Thrive team after the webinar. Finally, I'd like to let you know that we are recording this webinar, and the content will be made available on the events section of the Thrive program website. And you can find recordings of previous webinars and associated materials there too. And with that, I'd now like to hand over to Karina to present the team's research.
Wonderful. Thank you so much, Marlise, and thank you, Thrive, for having us. So I'm really honored to share today about the study that we ran in 2020, 2025 in 4 countries with the funding of from Lega Foundation with programs that were funded by Lega Foundation to scale parenting solutions. So just a few key facts about the study. We worked in Bhutan, Rwanda, Serbia, and Zambia. In each of these countries, parenting programs were implemented by a different organization, what we'll talk about in a second. And our goal was to generate evidence on effective pathways to scaling playful parenting programs and then serve as a learning partner throughout the way, sharing evidence throughout the way. We can see that this is a bigger research team. Francis and I are here. A few of our country investigators will be on the call, just in the audience, and you can see that we had investigators in every country, and we had research partners in every country, and so this was quite a collaborative effort across multiple time zones and countries. To give you a sense of the scope of the study, we looked at 5 aspects of these programs as they scaled, starting from child and caregiver outcomes, which are crucially important. We looked at community norms and community engagement. We looked at workforce as it changes, as programs recruit, hire, and train and support more and more frontline providers. We look at programmatic factors, which is the decisions that the program implementation teams make as they iterate programs, as they go to scale and adapt to changes. If you think about the fact that we started during COVID, programs had to adapt along the way. And then we have the enabling environment, of course, for scale up. So there are quite a few research activities that were taking place. We're not going to talk about all of them, but suffice to say, so for the child and caregiver outcomes, we focused on, we used the home inventory for caregiver outcomes, and then we used global scales for early development for child observation. And there were a number of different instruments providing implementation evidence along the way. The programs were quite different. We looked at 4 countries, as I mentioned, and all of these, in these countries, the programs differed in the types of providers they engaged, from health professionals, such as health assistants in Bhutan, to volunteers. In some cases, as you know, the Sugiyama Younger program, which was highlighted in this webinar series earlier, it was the ISUs, the social protection volunteers, and we had the nurses, which are health professionals in Serbia, and then volunteers again in Zambia. The modalities were different. You had home visits, you had group sessions, and then you had a combination of those 2 in Zambia. Intensity was different, and then importantly, how they defined scale. The fact that we saw a program go nationwide with that ambition from the beginning in Bhutan, that was very different from the program in Zambia, which had different program implementers working in different districts. And so the program that we were looking at was really intending just to scale within 2 districts. So that's a pertinent question of how do you define scale? So there's no hard universal definition of this is scale, this is sufficient and insufficient. There's actually a really excellent webinar series taking place this week with the Scaling Up Community of Practice, and there's a lot of conversations around that. We know that the health and education systems, particularly health systems, they serve hundreds of thousands of families, even at the lowest level. So we're drawing on the ExpandNet, the WHO definition of defining scale as deliberate efforts to increase the impact of innovation successfully tested in pilot or experimental projects so as to benefit more people and to foster policy and program development on a lasting basis. So there's a lot of things that to unpack in this definition. You see the impact, you see the assumption that it's previously tested, you see that the expansion, and you see that there's policy and program change and sustainability, this piece on a lasting basis. So the ExpandNet framework identifies 2 dimensions, horizontal and vertical, for scaling up. Horizontal, you're looking at geographic reach, larger number of caregivers, and then you're seeing impact at scale. There's a lot more in there. If there are materials that you can look up. And then the vertical is essentially integration into government health systems, policy and budget resource allocation with existing human resources. So, there's a whole host of indicators there that we'll talk about, but essentially it's about integration and institutionalization. Through our study, we're also offered indicators that are, the indicators of successful scale on these two dimensions. And there is a paper, there's a policy brief or research brief on specifically highlighting why we felt these came out as indicators of success. For horizontal scale, there's evidence of demand, that there is sufficient evidence that families want the program. There is evidence of reach. So there's expansion. You're not just expanding and implementing and going through the motions. You're actually able to reach families, all eligible families. And then within those eligible families, you're able to reach vulnerable families, and they have access to the program. And then within that, to ensure quality, you have a workforce to back it up, that the sufficient number of providers are trained and provided with supportive supervision. On the vertical dimension, we look at multi-sectorality, particularly on parenting programs and early childhood development. As you know, it's very important that stakeholders from multiple organizations and ministries are working together. And then, of course, adoption and ownership by the government is crucial. We need to see evidence of the fact that the government is willing and able to adopt and implement the program, and has identified the policy and finances to support this continued implementation, that piece on a lasting basis there. And then finally, these two are connected. The workforce is integrated into the health system and its information management. So the workforce, whatever frontline provider is chosen, is fully institutionalized with training and support, that it can continue providing this program beyond the life of a project. So what are the key findings on scaling for these two programs that we're highlighting? Actually, no, this is four programs. So we know that for all of these 4 programs that we highlighted, we're implementing at intended scale within those subnational levels. The reach and uptake, it was a challenge, and so programs reached varying levels of success with uptake and demand by participants. The numbers of frontline providers also were not sufficient to meet that demand, to really saturate the implementation to reach the families that really needed the program. We had also different levels of evidence of institutionalization. So in some cases it was limited, in some cases it was full. So we're really excited to talk about the case of Bhutan, where the Ministry of Health really issued that executive order that fully institutionalized, integrated the program into routine services. So that's evidence of that kind of vertical institutionalization. So what were those programs? I'm not, I'm representing the research team, so that just highlights from the program for your background knowledge. The program in Bhutan was called Prescription to Play, or C4CD Plus, in Bhutan. And it was scaled from an initial pilot. There was a lot of work sort of iterating and testing by Save the Children in collaboration with Ministry of Health, and then expanding that program nationwide in phases. The modality was group parenting sessions on a monthly basis, and they started with 12 sessions, and then they gradually went to 9 to reduce the load on parents, to make it a little bit easier to go through the curriculum. They were administered by health professionals, health assistants that were located in primary health centers and in outreach clinics. So, initially the program really focused on the rural families. And then later in the year also opened in the city, following a prescribed curriculum and a manual. And so each program, we observed the sessions, and so we found that they lasted between 20 minutes to 75 minutes, in some cases more, but that was sort of the range. And so in terms of their scale, evidence of how did they scale? So they did scale all districts nationwide in 2023. With the collaboration of the Ministry of Health. Attendance really varied. In our survey, we found that at least attending one session, in our survey sample, 44% families said that they attended one session, at least one. And then the workforce really talked about creating incentives for families, sort of offering some refreshments, in some cases for these group sessions, some other incentives. So, and that was, of course, raises question of sustainability, but that was something that consistently came up. And then the health assistants in this case were happy to implement the program, but they also noted that there's multiple things that we're implementing at the same time. And in some cases, there was just one person running that outreach clinic, and it was a little bit of, it was difficult for them, but they were excited and managed it. And then on vertical scale, the executive order that I mentioned, so we'll hear more about that implementation from like then. There, we found that the program aligned to flagship health programs. So talking about that enabling environment there, integrating into the health information system, and that, and very importantly, their pre-service and in-service training was integrated into the core university curriculum. The national university was a key partner for the program from the beginning, and they worked to ensure that there was institutionalized training, both pre-service and in-service, for health assistants. In Zambia, the program was based on Care for Child Development model, which is, as you know, implemented in several countries by UNICEF. We did not see when we came into the scale up as partners, we did not see that there was evidence of pilot and evidence of success at pilot stage and with this program in Zambia specifically. The program consisted of home visits by community-based volunteers. The community-based volunteers is a recognized frontline workforce by the Ministry of Health, and they were regulated by the health offices. But they are volunteers, and so there's a certain level of capacity building that needs to happen when you're working with volunteers. The they had counseling cards with play activities in 3-month bands. So a 3-month band of, the child would get essentially one set of play activities. So if they've already done them, they have to wait until the next band comes up to offer new activities to families. They introduced group sessions later to cover more families. And so that was interesting for us to observe. That was in the last year of the program. In terms of the reach and demand for horizontal scale, we found that 36 families in our sample at Endline had reported being visited by a CBV or attended a group session in the past 12 months. So slightly lower reach there. Then we thought that the community, we found in the survey that community-based volunteers were satisfied with the program, but they talked about the lack of compensation and incentives. For their time and for their transport, getting around to the villages was certainly a factor. And then we found through our observation that session quality varied substantially. So some sessions were just not getting to that opportunity to coach parents in responsive stimulation, communication, and play. And that was one of the challenges was that the lack of translated materials in local languages. So the CBVs, the volunteers, often had to translate on the spot into their local language from English. And then you had, for vertical scale, there was strong involvement of district level health officials in the training and implementation oversight. So they were quite involved in the program. And there were a lot of evidence of multi-sectorality, committees at different government levels. So there was evidence of those two pieces happening. However, there was sort of a continued process at the time that we left off of the information system where the CBVs, these volunteers, would be tracked and would be supported, but it was not as of the study completion effectively used. And according to the volunteers themselves, they were not given any incentives or sort of tracked in the system. And then they had, there was a lack of institutionalized training and supportive supervision. So the supervision really took place in the form of just reporting how many visits you've done. So that was we felt like that was really an indicator that would really need improvement in terms of vertical scale. Now, outcomes. So I'll talk about really quickly about outcomes. We have a paper. We have 2 papers that the Thrive team will highlight for you all. In both cases, we worked with, we ran observational studies. They're non-experimental, non-randomized, because we followed the process of scale up. And we, in Bhutan, we had a study. We've selected 7 districts. We initially structured them by phase of expansion. The phases ended up being truncated because of COVID. So And then in Zambia, we had 4 districts. So Katete and Pitauke were the districts where the program was implemented. And then we had 2 sort of comparison districts that were also in the Eastern Province where we sampled from. There was a panel sample in Bhutan that we were able to follow 500 families, around 500. In Zambia, we were not able to follow families, and so we had 2 independent samples that we had to put together. And they were kind of around the same time were completed. For the instruments that were of interest to us, we used the home inventory, as I said, for caregiver-child interaction. It's a 45-item inventory that there has multiple components of activities, and there's a component of interview with the caregiver. There's an observation of the play spaces, and there's an observation of the mother-child interaction or the caregiver-child interaction. And so each of these activities is a point in this 45-point scale. And then the child outcomes, the GSET, many of you are familiar with, that the scale that came out just as we were getting ready for endline, and that was direct observation of child developmental outcomes. In Bhutan, we found that the caregivers who reported attending at least one group session were likely to have a 0.54 or about 13% standard deviation higher score on the home inventory. So very modest, but it was there. And then we had a corresponding difference in GSET outcomes for the children of these families. We didn't find substantially greater coefficient associated with attending 4 or more sessions. There was a very small number of families that attended 4 or more sessions. If you remember, 9 were offered. I think that the average, sort of the median we found was about 4.5 sessions that they attended. So, this is really the majority of the sample here. So we had, for Zambia, we also looked at the program district, whether the program was different from the comparison districts, and they were pre-selected before we came in. Because the comparisons were sort of waitlisted, that's where the program was going. They were different at the start, and they continued to be different in terms of their level of on the home inventory. So 1.5 points on the home inventory at the end line, and then within those districts, we looked at the sort of the treatment and the treated, the parents who said that they were visited by a CBV. They had slightly higher score on the home inventory, but if they attended at least one group session, there was substantially higher. So almost 3 points on that 45-point scale were associated with that group session attendance. Now, mind you, this is something that we surveyed families, and those families that attended sessions might be different from families that have just been passively visited by a CBV, but that's quite a substantial difference there. You notice that there's no corresponding effect in child outcomes for Zambia that we found. So in summary, very modest differences in caregiver outcomes at scale in both countries, and associated with session participation, this observational study. We have differences in child outcomes associated with participation that are evident in Bhutan. So you can associate the home inventory and the GSET. You're finding sort of similar differences there, but not in Zambia. The intensity of participation and measure in Bhutan was not, we were expecting dramatically higher coefficients or correlations with higher levels of participation. But of course, it was difficult to assess because of the challenges with the uptake and retention of participants. And then a group session in Zambia, even though it introduced it in the last year, it appeared to be more predictive of higher outcomes. So that's something that really needs further exploration, and maybe through the more rigorous design. So key takeaways here, and I'll pause and we'll go to the discussion. Focusing on effectiveness and scalability of interventions. So we saw the programs iterating along the way, but really it was important to be looking at a program that was really designed for scale. So a program with an intervention that it has an intention and then a sort of a pathway to be integrated into the program, into the Ministry of Health system. It was important to ensure government ownership, as we'll talk about with the case of Bhutan from the outset, and having buy-in and alignment with the policies and ensuring that there's a path for integration was just impossible without full buy-in from the beginning from the government. And then continuously examining evidence and planning for these iterations and really testing them as we go to scale was crucial. And reviewing emerging outcomes implementation data. We were sharing all of our observation data, all of the survey data with providers back with the programs, our training observation data. And so we were kind of working in collaboration as an evidence partner so that the programs could use that evidence to continuously improve what they were offering. So with that, let me pause and give it back to Elise.
Thank you very much for that presentation, Karina. That was clearly a very comprehensive research program on scaling that you led, and thank you very much for sharing those outcomes and reflections. And welcome, Francis and Legden, to this conversation portion of the webinar. I'd like to kick off the discussion with a question for Francis about the 8 indicators of successful scale that were shared during the presentation. So just at a very high level, which of these 8 indicators would you say is the most important? And is there any best sequence to approaching these vertical and horizontal indicators?
Yeah, that's a very important question. And I would have to say that adoption and ownership by the government, to me, is the sort of sine non qua for really scaling up vertically. And it is, in fact, the most difficult. Langdon can talk a little bit more about this. But as I see it, as you already mentioned, it's important to get the government involved right from the start while you are conducting all of these other, evaluations and training of the workforce at the lower level. So I would have to say that that's critical, and it does sort of proceed. It moves along kind of gradually, but it's got to be there from the start. In fact, it's probably more important than just having a policy because many countries, most countries actually have an ECD policy, but they don't implement it. So the critical thing is that the government wants to take it on and is willing and able to adopt it.
Thank you, Francis. And that leads very nicely into a question for you, Legden. As Francis mooted, this seems to have been the case in Bhutan, that there was a lot of political will, let's say, from the beginning of the program. Could you describe how that came about and how do you get from policy to implementation? Maybe you can provide some insights on that.
Yeah, I think thank you, Francis, and thank you, Karina and Marilise, for really giving me this opportunity to represent Bhutan. I think Bhutan is fairly unique in the sense that every health system is free and is government-led, government initiatives, and we have a system of providing free healthcare and policies. And from the very beginning, when we initiated, it was actually led by the government program, one of the programs in the Ministry of Health, Department of Public Health. We always felt that child development is a very crucial sort of like important initiative that we need to take. And there's many reasons why mother and child is a very important initiative, very important area of development that Bhutan is considering. Particularly, our population is very low, and even now as we speak, we are struggling with trying to bring up the population. And for facts, we have just around 700,000 population. That's why we're able to give, and that's why everything is led by the government. So to begin with, And we were always thinking about quality, providing quality. And we had this program called Care for Child Development Program, C4CD, which was there for a long time. And then we wanted to do something extra. And that's how after sieving through many opportunities, we happened to partner with Save the Children and led by the government initially. And then we did a couple of pilots. And then this pilot and once we basically presented our findings and our potential and our potential outcomes to the management of the government, of our management, essentially, they were really excited. And that's how we kicked off this program. And later on, and we were in a way also very lucky because we had dedicated staff, dedicated support from our development partners, and also our health workers were very excited about this. And that's why we were able to scale up. So to give a short answer, I think it was essentially led by the government. So that's how it was very easy. And in Bhutan, every health facility services are centralized. Our planning is centralized. The Ministry of Health, Department of Public Health, where I belong, we essentially develop guidelines, policies. That is how our health system is structured. So once we have this endorsement, and once there are good ideas that are coming in, and once we have a successful pilot, then it becomes very easy for us to scale up, very easy to implement. And essentially, that is how I think, looking back our journey, because of our successful pilots, because we're able to showcase that it is important and it aligned with what the country has focused. Basically, mother and child health is a very important focus that we've have had. So I think this is how we were excited, and we were able to essentially adopt the program, so to speak. Right?
Great. Thank you so much for that description, and really a demonstration of there being, let's just say, political will in Bhutan supporting these initiatives. And I suppose we'd have to go one step back to then understand how does that political will come about. But that would be a topic for another webinar. But it's great to hear that once the political will is there, then having evidence to show that various programs do work and do have positive outcomes does have a big impact. Karina, if I might turn to you just to supplement what Legdan has described in Bhutan with maybe some of the experiences from the other programs in the other countries. Because as Legdan has said, in Bhutan, there is a top-down approach to these vertical indicators. There's a government commitment. What was the case, would you say, in Zambia? And maybe also if you can comment briefly on Rwanda and Serbia, and then also saying, is there, what were the outcomes relating to these different approaches?
Yeah, yeah, and I think maybe I'll just say that I think in Bhutan what we saw it was really happening on both levels. There was both sort of that bottom up because of what Leighton describes is this work towards looking at what actually works on the ground and trying to sort of iterate and scale that and creating that policy and a framework and creating a resource environment eventually that the two would meet, and then also focusing on that middle tier of the districts where the districts would support the program implementation. And I think it's very important that there's both of these trajectories were engaged at the same time. And I think that we also should highlight the fact that it was just when we came in as evidence partner. I remember that one of the first visits where we talked about the baseline data and the design of the study. It was actually the Ministry of Health that, like then, they were asking us for data. What is the data? Where's the data? Where's the evidence? How is this working? And that interest and then sort of this ownership of the process. And I think at the end of the day, it wasn't something that where a program came in and said, can you scale this? It was a collaboration where it's like, how do we resolve this issue? How do we provide this solution and messaging to as many families as needed, and working on both sides. In other countries, we found slightly different dynamics. In Zambia, it was certainly in Serbia because it was UNICEF. UNICEF is very strong on like multi-sectorality, very strong on working and engaging governments and working at the policy level. So that's where they put a lot of emphasis and sort of like establishing that environment. We saw less of this sort of the bottom-up iteration and really focusing on the piloting and really honing the intervention. And so that was certainly, maybe a disadvantage coming into the scale-up process. And then in the case of Sri which of course, you profiled in the earlier webinar, that was really focused on the intervention itself, a very strong intervention. And so that's where the program was honing its quality. And then in later stages, sort of working with the relevant agencies to integrate their program. So that process when we left off was still ongoing. So it's a bit more of a bottom up and engaging the government there. I don't know if that, Francis, you want to comment on that? Yeah.
Yeah, I was wondering, Francis, if, based on your other experience, have you actually seen any examples where you've started with an innovation that is, trialed successfully through, with an NGO and starts very much at a community level and only gets taken to government at a later stage? Just, this is a broader question. Have you seen that approach being successful?
It's very rare. It's very difficult because in many countries, there are many different organizations implementing. They tend not to get together, even though they should, to form coalitions and, blanket the country. But they're all interested in their own. And there's some very, very effective parenting programs around the world that just never break the ceiling to get up to the government. The government doesn't feel any need to, and maybe they're playing off one organization against another. So it's frustrating and it's difficult because we see very good programs that governments should be adopting, and we see programs that are really very mediocre that are adopted by government from the start simply because they get funding from an organization. Yeah. And then they have big problems. There's a huge gap then between what the government's doing and what's happening on the ground.
Great. Thanks very much. It's super insightful.
I
Karina,
could
did you
just
have
add,
something you wanted to
yeah,
add?
I would just add, I think that it's in the government and particularly the ECD coordinators are in this position where they're having to juggle multiple programs and and really coordinate them. And they're not always sort of in a position, or they don't believe that they're in a position to identify a core set of parameters and really kind of enforce that. A uniform process and coordinated process. So we saw in Zambia, for example, different organizations implementing in different parts of the country, and with slightly different, similar messaging but slightly different approach. So these volunteers would say, well, in that village or in that district, like they're getting bikes or they're getting incentives, they're getting money. Here I'm not getting. So like it's that, and then they're getting this many sessions, they're doing this way. So it's okay to iterate and look at what works and what's scalable, but at some point, these things have to connect, and then that's where it really suffers, that there isn't a uniform sort of top-down approach and a desire to, at some point, to connect the dots and have a structured offering for families across the country, or at least a larger swaths of geographic territory.
Great. Yeah, having that consistent view is an overview is super important. I was thinking also when it comes to workforce, this is another topic that's really central to expanding the reach of the program, and the choices around that. And exactly, you might have different work, as you're just describing, Karina, different workforces promoting or delivering different kinds of programs. In Bhutan, like then, it seemed very much that there was consensus around which workforce to use, and a very concerted effort to train that workforce, starting at the university level with input from the training courses at the universities. Was there any debate up front about which workforce to use? And were there pros and cons that were considered? Yeah, what went into the choice in Bhutan?
I think our choice was we had no choice, essentially, because our primary healthcare is we are very structured, and I think Bhutan is because everything is state funded, everything is government funded, so we have a very good primary healthcare system. In fact, we have won many awards, and one of our grassroots worker has always been our health assistants. The problem is that I think there were debates essentially, not like who should be actually delivering this program. We did in the very, very initial phase, we did consider we have a voluntary village health workers in the communities. They are situated in communities, but then we were very clear from the beginning that if we wanted to implement this, it has to be scalable, it has to work, it has to be of quality. So, I mean, there was for a very brief moment when we talked about village health workers. Then I think we even tried to pilot them, and we very quickly we learned that I think we would not be able to deliver in the quality with the quality that we would expect. So we didn't. We really couldn't consider village health workers. And then the second reason is that our village health workers, there was a lot of attrition rate, and also some of them were not really literate, so to speak. So I think they're just voluntary community workers. So we would have had difficult time delivering. So then we just switched to our health workers who are paid by the government, who are employed by, and they're working in the communities, and actually they're part of our community health workers, and then they deliver all services. So, but then there was another issue with this because they're in the communities, they were delivering a lot of program that which I think. Really highlighted huge efforts. Then how do we get their buy-in, right? How do we get our health workers to really deliver the interventions that we desire and that we want in a manner and in the quality that we want? So a lot of work did go into this. Firstly, we started with the in-country uh, p- uh, pre, in-service training programs, huge training programs, massive efforts that went into trying to train them. And then, well, not only that, there was massive efforts on the monitoring, massive, and then following that, we also worked with the university to again look into the quality aspect. We, in fact, have a very independent but very similar quality assessment, quality improvement initiative, which was conducted together to ensure that there was a delivery of quality program. And then together with our university, we also incorporated, we also develop for pre-service courses so that we don't have to. But then having said that, pre-service is one thing, but in order to really be successful, we still need to to continue our refresher courses, so on and so forth. So we also have this online courses that we develop, and if there is, and then we also continue to deliver this. So in
Great.
essence, when we first, it's just one choice, right?
Super. Thank you. Yeah, very much. And just very briefly, maybe, uh, in a health system or for delivering parenting programs, there's not always necessarily a choice of workforce. In Bhutan, there's clearly a very well established system. We're just talking about Rwanda and the EZUs there, and that was kind of an established workforce. However, there really are very different training needs across different types of workforce. If you're talking about volunteers, if you're talking about professionals, if you're talking about paraprofessionals. But maybe also either Francis or Karina, just at sort of globally, would you maybe say that you'd recommend a particular type of workforce, if you're to consult to government and recommend a kind of workforce that they would use to deliver parenting programs?
I'd have to say that I think paraprofessionals would be a good source also. These are like community health workers. They're not volunteers. They are really part of the system, but they're paraprofessionals, and they definitely could do the job. It is the case that if you have I think all of the providers benefited from having a manual that was structured and prescriptive with all of the activities that they should be doing with parents laid out explicitly. Now, if you have volunteers, as they did in Zambia, you need a much more structured, explicit program than the one that they had. So they were delivering it just fine, but it was not direct enough either for them to understand what they were doing or for the caregivers to understand what they should be doing. So, the provider that you choose, yes, it often is determined. I think in Rwanda, there were a lot of community health workers who were involved delivering nutrition and other programs, but they were already too busy. Everybody downloads their work onto the community health workers. Yeah, but you do have to fit your program to the provider and to the caregiver.
Absolutely. Great.
Yeah.
Well, thank you very much. I'm wanting to keep some time for questions from the audience. So if I can now turn to questions that are coming in. First question from the audience. This is actually directed to Karina on Zambia. And it says that this sounds like an ambitious program of services innovation. And I'd be interested in understanding how many years you thought was necessary to achieve organizational maturity. That is to say, where the workforce and the organization supporting them has, in some sense, achieved a threshold maturity. Or
That's such a great question. And I think it's for the whole panel. I think so. All right. So we work with Liga Foundation as sort of as an evidence partner to them as well as a funder, right? And so when we pulled together the lessons from the study, we said, if you're looking at scale and you're looking at system transformation, and really that's something that stays and makes lasting impact, you can't be looking at these like the short-term project cycles of 3 to 5 years. And in the case of these programs, they were truncated because they started in COVID and they had to complete within a shorter time period, right? And so, but you weren't necessarily coming in already somewhere in that pathway. Somebody was already working before then. So ideally, if you're building in that continuity, you're able to pick up and sort of continue that maturity. But we were saying, well, recommend 10 to 15 years of that level of lifespan for programs to mature, for organizations to mature. And that presumes it's not necessarily the one and the same thing, but there is that continuity, there's commitment to that pathway. So in the case of Zambia, they were bringing in evidence from another country. So it had to be tested. It had to be iterated. It was just not enough time for them to figure out all of the pieces before they went to scale, and what we observed. And so the scale was modest, but it was also happening in other countries at the same time. So the attention of the government was really sort of looking at the entire thing. So it really, I think, was the expectations that they would be effective were just, we were just really concerned from the beginning, let me just say. And Francis, I know that you have thoughts about that, and LinkedIn, I'm sure it's such a great question.
Yeah, it is very difficult. And I think, as you said, a program that's already been operating in the country and has some evidence of effectiveness, that's a good start. And then, of course, these other things need to take place. And some governments are very swift, as they were in Bhutan, getting involved and moving along, and others were slower.
Great. Thank you very much. Another question from the audience. I think, Francis, you may have made some comments about this already in the Q&A responses, but it's a very interesting question about community norms and community engagement. And this also, feeds back into sort of what is the baseline that you're operating in when it comes to providing parenting programs and encouraging caregivers to adopt different behaviors, essentially, and to change behaviors. And so the question is a little bit like, are there very different, did you encounter very different, what I'm calling sort of environmental baselines in different countries? Or would you say it's pretty common across the board what attitudes are towards, knowing about parenting or not knowing about parenting? And
Right. I mean, there
programs?
has been some evidence for this, and it really does seem to mean that the SES and education level of parents largely determines how receptive they are to changing their parenting behaviors and breaking away from community norms. So I would say that Zambia and Rwanda had the most their norm for parent engagement was to provide nutrition and good health. And in many cases, they just thought that the mental development just came along with those two things. You didn't need to do anything special. So it was quite unusual for them to hear that it is important to, from birth, talk to your child. They really didn't even think that a child could hear you or see anything. So that was an important norm to overcome, and parenting programs have to overcome that norm, partly just by talking to parents who are prepared to, adopt something new, but also to do some societal or community advocacy, with bulletin boards or television, radio, and so on, to make it clear to people that this is a norm. This is not, you're not on your own doing it. And that's what makes it difficult. Of course, there were strong norms also about involvement. In all of these countries, there were norms against father engagement. Now, we know that. It was that way where I was living also, so there's nothing new. Fathers were seen to provide material and economic things, but not engage in childcare. We noticed that particularly in Rwanda and Zambia, that fathers were insulted and humiliated by community members if seen to do something in public, like take their child to a clinic. So that was very difficult for fathers to overcome. But these were norms for all countries to deal with.
Very, very interesting that you should bring up the issue of father engagement. In fact, our last webinar was about fatherhood programs and featured Banda Bereho and Real Fathers. This was in Uganda and Rwanda, respectively, and the success that they've had in scaling. But they really emphasized the amount of sort of mentoring and one-on-one interaction that was required to bring about these changes in norms, and it's a very gradual process. But perhaps thinking that maybe parenting programs could either incorporate some of these lessons from fatherhood programs and where fatherhood programs are seeing success, so sort of incorporate that into their programming, or collaborate somehow in delivery of programs together with fathers. So on that question, it's related, maybe a bit duplicative, but there's a question from the audience about when it came to the caregivers who were involved in these programs, was it mostly mothers? Yes, and so it sort of relates to what you just said. Maybe there's quite a bias or a stigma against fathers, but maybe Francis, I see that you might want to step in there, but I'd be interested also perhaps in what Legdon might have to say. Given the impetus and the commitment to these problems, what Bhutan might be doing to approach fathers as well. But Francis first, and then Legnan, if I could pass that over to you.
Yeah. Okay. So the real problem with fathers is, I mean, mothers, yes, they were the main participants in these sessions. For fathers, in many cases, they won't come to a parenting program where there are children. So home visits may be a little bit easier because you can shoo the children out of the house while you're delivering your message. And in Rwanda, they had a lot of messages about marital harmony and controlling emotions and domestic violence. So 44% of our observed home visits were attended by a father in Rwanda, whereas it was a little bit lower in Bhutan and quite low in Zambia. I think that one of the problems, obviously, for fathers is that they're not available during the day when the parenting sessions take place. So you have to arrange a different time for them. Now, some of the Bhutanese fathers did say at the end, yes, they sounded very interesting, and our wives told us what they had learned. So they got it indirectly, and fathers were willing to go along a little bit with what their wives were asking in Bhutan, but still attendance, even at one session, was low. Fathers were, of course, invited to all of these, but they were reluctant.
Thank you, Leighton. Yes. Over to you, Leighton. Thank you.
Yeah, really 80-90% were mothers who really attended the sessions, and there is a concerted efforts to get in fathers. We invite them, and in fact, right from I mean, even before the child is born, right, from maternal child health programs, we have been always encouraging fathers. Involvement is a very important aspect, from kangaroo mother care aspect, and even for this. For our CIFO City Plus program, or rather P2P program, we have been inviting, and in fact, there's a specific program designed just for a session called Father and Me. No, so we have this specific session in one of the 9 sessions. We do have one dedicated program specifically for. So despite this, there have been difficulties, but I haven't looked at the latest statistics. But I think we should be improving, but we still have challenges with this, and the reasons of why they may not be coming is, I think most fathers probably are engaged in work, and they're not available, like Francis mentioned, and not necessarily because they may not be interested. And one thing is, culturally in Bhutan, we do not have a very big, how should I say it, big discriminatory sort of thing against father attending these programs. In our Bhutanese case, probably it is because I think they were not available, or simply ignorant, so to speak, on how to get, and it's always been seen as. But at the same time, if the fathers do attend, there is no discriminatory remarks that goes on. So this is a added advantage, and we have been trying, and I do see there are a lot of encouraging signs that we see a lot of programs. And how do we get them more? I think we need to keep on educating, we need to keep on advocating, and then we also need to really, through mothers, if they're not there, to really ask them to come and be important part of their child development.
Great. Thank you very much. I'm afraid this is all that we have time for today. There's still some questions in the chat that I'm hoping that we'll be able to answer offline. Keep an eye on our events page for follow-ups there. But for now, I think I would just like to say a very big thank you to Francis Aboud, Karina Umueva, and Leighton Zed. Thank you all for joining us today.